Let's talk about splenic disorders now. And before we talk about splenic disorders, let's talk about the anatomy of spleen. A lot of questions which we discuss in the conditions later on can be understood if the surgical anatomy of spleen is clear in your mind. Now, splenic anatomy, you need to know that spleen lies along the long axis of the 9th to 11th rib. So the long axis of the spleen is along these ribs. And what is the clinical importance? This I've covered in the thoracic trauma module. That if there is fracture of 9th to 11th ribs, if there is fracture of 9th to 11th ribs on the left side, that can give rise to splenic injury. That is the importance of knowing this. Which is why if there's any bruising on the lower side of the chest or fracture of the 9th to 11th ribs, you should always suspect splenic trauma. Now, the spleen can enlarge, and if it enlarges, then you can palpate it in the abdomen. Now, when we palpate, there is a notch along the superior border. This question has also been asked in multiple exams. And the downward displacement, so you will notice that the spleen tends to grow more medially, not downwards. The downwards displacement is prevented by the phrenicocholic ligament. So this is again a very important point which I want you to remember. The downward displacement is prevented by the phrenicocholic ligament. Now, there are various ligaments in the spleen and you should know about them because they are also surgically important. So these are the various splenic ligaments which are there. The phrenicocholic, I've told you, prevents the downward displacement. The splenicophrenic and the splenicocholic are avascular ligaments. And what is the importance of this? The importance is that these can be cut. These can be cut during splenectomy. So you can cut these ligaments during splenectomy without fearing that there will be bleeding. So these two are avascular ligament. The gastrosplenic ligament has the short gastric vessels. You know, short gastric vessels are given out by the splenic artery itself, and these need to be ligated when we are doing a splenectomy. And finally, the linorenal ligament is the one which has the splenic vessels and the tail of pancreas. And we need to be careful while we are doing surgery as to ligate the splenic vessels and to prevent injury to the spleen. So this is the linorenal ligament, this is the spleen, and this is the kidney. So linorenal ligament, and in this is where the tail of pancreas and the splenic vessels lie. This is the gastrosplenic ligament, where this one is the gastrosplenic ligament, where you have the short gastric vessels, Now, you need to know that the splenic artery is a branch of the celiac trunk. So this is my celiac trunk, and this is the splenic artery which is given off. And the splenic artery travels on the superior border of the pancreas or behind the pancreas, and it goes and supplies the spleen. Also, you need to know that the splenic vein joins the superior mesenteric vein to form the portal vein. Now, one thing which is important in the surgical anatomy of the splenic artery, which I want you to know. So like I told you, the splenic artery is traveling along the superior border of the pancreas or just behind the pancreas, and it divides and supplies the spleen. Now, this division, there are two variants. This one is known as the magistral type. The magistral type of splenic artery, which is seen in 30% patients. Or the other one is the distributed type, which is seen in 70% patients. So the magistral type is the one where the splenic artery, divides into polar arteries and terminal arteries close to the hilum of the spleen, right? Whereas the distributed type is where division is far away from hilum, right? So this has an importance while we are carrying out splenectomy. We need to know whether it's a magistral type or a distributed type, because accordingly we can either ligate the main trunk or we can ligate the vessels while we are carrying out a splenectomy. So these were the points in the surgical anatomy which I wanted you to know for your exam. The functions of spleen of course plays a major role in the immunological response. So the antibodies which are produced, the IgMs and the IgGs which are produced are a function of a spleen. It has a filtration function and a pitting function. So basically the abnormal RBCs which are there, the abnormal cells which are there, spleen acts as a graveyard for those cells. Hematopoiesis, so during embryogenesis, there is hematopoiesis which takes place for some time in the spleen, and this is usually in the 3rd to 5th week. This is usually in the 3rd to 5th week of the intrauterine life. But in various myelodysplastic syndromes, spleen can act as the major site of extramedullary hematopoiesis, right? So extramedullary hematopoiesis can occur if there are hematological conditions which are occurring in the patient. Also, it is a major reservoir for all 3 cell lines, including platelets. And this is very important because whenever we carry out a splenectomy, there is transient increase in all 3 cell lines. But most notably, there is thrombocytosis. And because of this thrombocytosis, thrombi can form, thrombus formation can occur, which is why we need to be careful about prothrombotic states following splenectomy. Right, so these are the functions of spleen which you should know about. Now, 2 conditions, one is spleneculi and the other one is splenosis. So these 2 terms we should know about. They have been asked in the exam. Spleneculi are accessory splenic tissue. Spleneculi is accessory splenic tissue. And the most common site for spleneculi is the hilum of the spleen. The most common site is the hilum of the spleen. Now, why is this spleneculi important for me? This is important because if splenectomy is being done for hematological conditions, like ITP, idiopathic thrombocytopenic purpura, right, or in thalassemias or in lymphomas. So if we are doing splenectomy for hematological conditions, and if we forget spleneculi, then there can be recurrence. That is why we need to actively search for these spleneculi when we are carrying out splenectomy. What is splenosis? Splenosis is that following trauma, so supposing there is abdominal trauma which occurs, and following trauma, splenic particles can get deposited in the omentum, bowel, they can get deposited in the bowel, right? And they can gradually grow. And when they grow, they can appear like a tumor. It appears tumor-like. And when you do a CT, you will see these multiple nodules all over the abdomen. And you will feel that this is a tumor. But when you do a biopsy of these lesions, it is just splenic tissue. It is normal splenic tissue. So it appears like a tumor, but it is just splenic tissue, and this is known as splenosis. And the most significant history which you are going to get here is following trauma. So if you get a question stem like this, always look for this sign that they must have given a history of abdominal trauma. The next topic is splenic cysts. Now, splenic cysts can either be true cysts or they can be pseudocysts. They can either be pseudocysts or they can be true cysts. So, of course, pseudocysts are not lined by any epithelium. True cysts will be lined by epithelium. Pseudocysts are most common cysts. Pseudocysts are the most common cysts in the pancreas. This you should know about. And again, pseudocysts are formed post-trauma. So post-trauma is where you're going to get pseudocysts in the spleen. And majority of these of the times they are managed conservatively. You don't require surgery for these pseudocysts. You can see in the image, this is a well-defined pseudocyst which you can see. Again, you will have a typical history that this is developed following trauma. So history of trauma is going to be there. Now, true cysts, the most common true cyst of the spleen is a parasitic cyst. So most common true cyst is a parasitic cyst, and this is hydrated cyst. So we've already spoken about hydrated disease of the liver. There can be hydrated disease of the spleen as well, which is managed pretty much on the same lines as hydrated disease of the liver. If it's a large symptomatic cyst, we even need to do a splenectomy in these patients. There can be dermoid cysts and there can be epidermoid cysts present as well. So these epidermoid cysts which are there, these epidermoid cysts are seen in children. These epidermoid cysts are seen in children. They usually have flattened squamous epithelium. They usually have flattened squamous epithelium. And if it is more than 5 centimeters, we have to carry out excision. And if it is more than 5 centimeters, we have to carry out excision of these cysts. So this is the splenic hydrated cyst. You can see the daughter cyst growing inside. And I've told you that if it is large and symptomatic, then we need to carry out a splenectomy in these patients. Another very important topic for the exam is a splenic artery aneurysm. Splenic artery aneurysm, if you remember the module on arterial disorders, I told you that splenic artery aneurysm is the most common visceral artery aneurysm. It is the most common visceral artery aneurysm, and this question has been asked multiple times in the exam. Now, this visceral artery aneurysm is formed secondary to pancreatitis, right, which is a major cause of aortic artery aneurysm, that is pancreatitis. It can be secondary to trauma, or it can be secondary to atherosclerosis in adult patients. It can be secondary to atherosclerosis in elderly patients, right? But the most common cause is pancreatitis. Now, splenic artery aneurysms, the clinical features, it is asymptomatic. Patients remain asymptomatic unless there is a rupture. Unless there is a rupture, these patients will remain asymptomatic. And if there is a rupture, the patient is going to present with there'll be features of splenic rupture. So what are the features of splenic rupture? The patient is going to have abdominal pain. There will be hemoperitoneum, right? There's going to be hemoperitoneum. And Kerr sign will be positive. Kerr sign is positive. We've discussed Kerr sign when I told you about splenic trauma. And splenic trauma, I've told you, I've covered in the abdominal trauma module. So that I clearly want to highlight again. Splenic trauma has been covered in the abdominal trauma module. I'm not repeating it here. So for splenic trauma, you can refer to the abdominal trauma module for details. What exactly is Kerr sign? Kerr sign is that if we lift the left lower limb, in patients, then all blood will go beneath left dome of diaphragm, and when it goes beneath the left dome of diaphragm, it will cause referred pain to left shoulder tip. And that is Kerr sign, which can be seen in splenic rupture. On examination, if there is no rupture, a bruit can be heard over the aneurysm. And the investigation of choice is CT angiography. Now, one thing which is very important, which I want you to know here, is that majority of these aneurysms occur before 45 years of age, and they are very common in pregnancy. In fact, rupture is most common in the 3rd trimester of pregnancy. Rupture is most common in the third trimester of pregnancy. So this you should know about. This is a very important point. In elderly patients, it is secondary to atherosclerosis. In elderly patients, it is secondary to atherosclerosis. Rupture is less likely. Rupture is less likely. There is calcification of the wall and rupture is less likely. Okay. So most commonly rupture is occurring during pregnancy. So like I told you, rupture can occur in pregnancy, and if rupture occurs, there is very high mortality rate as well. There is a very high mortality rate as well. Now the management options which are available, are you can do endovascular embolization, or grafting can be done in the endovascular fashion. So that is the first line of treatment which can be done. Otherwise, open surgery can be done. Open surgery is where we can do proximal and distal ligation. Proximal and distal ligation of the sac. And the third option which is there in these patients is we can carry out a splenectomy. So these are the three options which are there in patients with splenic artery aneurysms, and this is an important topic which you should know from this module. So this is a splenic artery aneurysm. The investigation of choice is a CT angiography, and on the CT angio you can see the aneurysm here. This is the aneurysm in the splenic artery. This is the spleen. This is the spleen, and you can see the aneurysm there in the artery. Now, splenic infarcts can also occur. Splenic infarcts are usually seen in patients with, hypersplenism, where the spleen is enlarged. Usually seen in patients with hypersplenism, where increased spleen size is there. And this is typically seen in patients with portal hypertension, and it is seen in patients with myelodysplastic syndromes. MDS is myelodysplastic syndromes. And when there is an infarct in the spleen, the clinical features with which the patient is going to present is abdominal pain. There can be abdominal pain. There can be pleuritic pain which this patient can have. And there can be referred pain to left shoulder tip. There can be referred pain to left shoulder tip. So these are the findings with which the patient is going to present. The investigation of choice again in these patients is a CECT. And when you do a CECT, you can see the infarcted area here, right? This is the infarcted area which is seen. Now the management of these patients are, if the patient is asymptomatic, we just carry out observation. But if the patient is symptomatic, or in these patients, if an abscess develops, so either the patient is symptomatic or if an abscess develops, then we have to carry out surgery to remove that area or to carry out a splenectomy in these patients. Now, when will a splenic abscess develop? So, splenic abscess is only seen in immunocompromised patients. It is seen in immunocompromised patients. So, that will be the key word which you need to look out in the question stem. For splenic abscess, you need to look out for the key word, that is, it will be an immunocompromised patient. And what are the conditions which can give rise to, which can predispose to a splenic abscess? So this can be seen in patients with hypersplenism, secondary to infarct. It can be a secondary to infarct. It can be seen in otitis media. There can be sepsis. There can be otitis media. It can be secondary to pancreatitis. It can be seen in typhoid fever. As well. And in these patients, what is going to happen, that there is high mortality. Once this occurs, there is a high mortality rate in these patients. The clinical features of splenic abscess are going to be, there's going to be pleuritic pain, there's going to be pleuritic pain, there's going to be abdominal pain which can be there. So pleuritic pain, abdominal pain, patient can have fever, but splenomegaly is unlikely, right? So usually the spleen is not enlarged. Splenomegaly is unlikely. This is another thing which you should remember for your question stem. So if you're answering questions based on this, you will notice that splenomegaly is unlikely in these patients. The investigation of choice is a CECT, and you can see on this CT, you can see a well-defined abscess here. You can see a well-defined abscess in the spleen. Now, the management of a splenic abscess is that if it is unilocular, we will carry out pigtail catheter insertion. We will carry out pigtail catheter insertion. I've already shown you pigtail catheters at various places. I've shown you pigtail catheters in liver abscesses, in the module on postoperative fever. I've shown you pigtail catheters there as well. But if it is a multilocular abscess, then we have to carry out splenectomy in these patients. So this was regarding splenic abscesses. Now, what are the indications for splenectomy? So this is a table directly from Bailey. The indications for splenectomy are trauma is the most common. And this can also be accidental trauma, which occurs secondary to accidents, or operative trauma as well. So operative trauma, I want to tell you that I still remember that I was a second-year postgraduate and I was assisting my senior resident, and we were dealing with a case where the patient had come where there was a gastric perforation, and while doing this gastric perforation, inadvertently the spleen got injured and we had to actually remove the spleen because we couldn't control the bleeding. So such situations can also rarely happen. Of course, following trauma, there can be splenic injury as well. And I love playing cricket. This is a picture of me playing cricket. And I remember in this tournament, there was a person who got hit, and he got hit on the left side. So a right-handed person, when he was taking stance, the left side was in front, and he got hit with a ball from a fast bowler on the left rib cage, and he suffered a splenic injury. Of course, he did not require splenectomy because it was a low-grade injury, but splenic trauma can happen following sports injuries as well. Splenectomy can be done as a part of the oblique resection. This can be done following pancreatic cancer resection or gastric cancer resection. Diagnostic and therapeutic indications can also be there. Hematological conditions, I've told you, they can be spherocytosis, hypersplenism. It can be secondary to tumors as well, and it can be portal hypertension. So portal hypertension, you should know that there is something known as left-sided portal hypertension, which I've covered in detail. This is also known as sinistral portal hypertension. This is known as sinistral portal hypertension. And for left-sided portal hypertension or sinistral portal hypertension, the management is splenectomy in these patients. So the most common benign tumor of the spleen is a hemangioma, whereas the most common malignant tumor of the spleen is lymphoma. Most common malignant tumor is lymphoma, for which also you might need to carry out a splenectomy. Metastases are rare in the spleen. Metastases can be seen secondary to gastric cancer, pancreatic cancer, but they are uncommon in the spleen. Now, these were the indications for splenectomy. Splenectomy can either be carried out using open methods or using laparoscopic methods. So splenectomy can either be open splenectomy or it can be laparoscopic splenectomy. And the major steps in splenectomy I've highlighted here. So step 1 is dissection of the spleen. Step 2 is dissection of the lateral aspect and the ligaments, the retroperitoneal attachments. Step 3 is we transect the hilum. I've already told you about the magistral type and the distributed type of the splenic artery variations. We dissect the short gastric vessels, and finally we remove the spleen. So these are the 5 broad steps in splenectomy, which I am highlighted here. What is a very important topic from the point of view of the exam are the complications following splenectomy. This is super important. Majority of the questions regarding this module are focused on the complications following splenectomy. So the complications can be hemorrhage. This hemorrhage can be primary hemorrhage, which is during surgery, or it can be reactionary hemorrhage, which we've discussed can occur 4 to 24 hours following splenectomy, which occurs basically due to dislodgement of the clot or slippage of the ligature. The other complications, intraoperative complications, can be injury to the pancreas, and this is the tail of the pancreas, which is closely associated with the hilum of the spleen. So this tail of the pancreas can get injured, right? And if this tail of the pancreas gets injured, how will the patient present? There'll be turbid fluid. in the drain, and this turbid fluid will be rich in amylase. And the management is majority of these patients are managed conservatively, and just drainage, and with time this fistula will stop. So a pancreatic fistula usually stops on its own. Another problem can be that while dissecting the short gastric vessels, there can be injury to stomach. There can be injury to the stomach, especially the greater curvature. This greater curvature, there can be some injury, and this can manifest as hematemesis. Again, majority of the times the management is conservative in these patients, and it settles down with time. Conservative management, and it settles down with time. So these are the intraoperative problems which can occur. Postoperatively, the most common complication following splenectomy, this question has been asked multiple times in the exam. The most common complication following splenectomy is left lower lobe atelectasis. Atelectasis, is collapse of the alveoli, and it is predominantly on the left side because the spleen is on the left side. So left lower lobe atelectasis, this will occur on postoperative day 1. POD is postoperative day. If we don't correct this with chest physiotherapy, this can develop onto pneumonia. So these respiratory complications are the most common, and pneumonia can occur by postoperative day 2 or 3. This question has been asked multiple times in the exam. Please remember that OPSI, that is opportunistic post-splenectomy infection, will not occur on day 1 and day 2. So if you're given a question where the patient is running fever after splenectomy on day 1, day 2, day 3, it's most likely due to pneumonia rather than OPSI. There can be hematological changes which can be there following splenectomy. So there can be hematological changes. What are the hematological changes which can occur? Hematological changes can either be transient hematological changes, or there can be permanent hematological changes. So transient hematological changes for 2 to 3 weeks. There can be increase in red blood cells, increase in WBCs, and increase in platelets following splenectomy. Now, increase in WBCs, if supposing you are the intern who's posted in the surgery ward and the patient has had a splenectomy, and if you see that the WBCs are raised, you can mistake it for an infection. It can be mistaken for infection. So we need to be careful to see whether other signs of infection are there or not. And there can be increase in platelets. And this increase in platelets is why we are carrying out splenectomy for ITP. In idiopathic thrombocytopenic purpura, we want the platelets to increase. And you should also know in ITP, platelets are transfused platelets are transfused after ligating splenic vessels. After ligating the splenic artery, we will then transfuse platelets, otherwise those platelets can get destroyed. Okay. And these increased platelets can also induce a thrombogenic state. If the platelets increase to more than 10 lakhs, if the platelets increase to more than 10 lakh per cubic millimeter, that can induce a prothrombotic state. And in these patients, we need to start these patients on prophylactic aspirin. This is written in both Bailey and the latest Sebastian. If the platelets increase more than 10 lakh, you need to start these patients on prophylactic aspirin. Now, the permanent hematological changes which can be seen following splenectomy are the presence of Howell-Jolly bodies, in the blood, in the peripheral smear. You can have basophilic stippling. There can be basophilic stippling which can be there. There can be reticulocytes in the peripheral smear. And there can be hypersegmented WBCs. There can be hypersegmented WBCs which can be seen. So these are some permanent changes which can be seen following splenectomy in the peripheral smear. Now, another major complication which you should know about is OPSI, and a lot of questions have been asked regarding OPSI as well. OPSI stands for opportunistic post-splenectomy infections. It is opportunistic post-splenectomy infections. Now, opportunistic post-splenectomy infections occur due to encapsulated bacteria. They occur due to encapsulated bacteria. And these encapsulated bacteria, the names have been asked in the exam. The most common being pneumococcus. The most common being pneumococcus. The other organisms are Haemophilus influenzae, and meningococcus, right? So these organisms can give rise to post-splenectomy infection, which there are certain points which you need to remember. It has high mortality. So if these infections occur, they have high mortality. They are seen in children more commonly than adults because in children the immunity is not well developed. They are commonly seen in the first 2 to 3 years, after splenectomy, which is why you will read some guidelines where they say, that is why they say in the first 2 to 3 years after splenectomy in children, we should use prophylactic antibiotics to prevent these infections. And one very important thing which you should know, it is more common when splenectomy is done. When splenectomy is done for hematological conditions as compared to trauma. For hematological conditions greater than trauma. And the reason for this is, I've told you, in hematological conditions, we will even search for the spleniculi, the accessory splenic tissue, and we'll try to remove those as well. Whereas in trauma, we are in a hurry and we don't search for those spleniculi. So some form of immunological function is still left. That is why it is more common when it is done for hematological conditions as compared to trauma. Now, how do we prevent OPSI? How do we prevent OPSI in patients? So, prevention of OPSI is by vaccination. And vaccination for all these agents, if we are carrying out an elective splenectomy, that means if we know when the spleen is going to be removed. So, elective splenectomy, it should be at least 2 weeks before. At least 2 weeks before splenectomy, we should carry out the vaccination against these organisms. But if an emergency splenectomy is being done, it should be given on post-operative day 1 or 2. It should be given as soon as possible after surgery. Right? It should be given as soon as possible after surgery. But you should remember that the antibody titers the antibody titers are more if vaccine is given before surgery. Is more if vaccine is given before surgery. That is when the antibody titers are more. So this is a very important statement which has been asked in the UPSC exam as well. So you should remember that pneumococcal vaccine should be given after 2 years of age. It should be given after 2 years of age, and pneumococcal vaccine should be repeated. It should be repeated after every 5 years. It should be repeated after every 5 years, the pneumococcal vaccine, right? Haemophilus vaccine and meningococcal vaccine can be given at any age. And Haemophilus influenzae vaccine is repeated after 10 years. It is repeated after every 10 years, right? So these are the points which you need to remember regarding vaccination. Second is antibiotic prophylaxis. So antibiotic prophylaxis, it is either in the form of penicillin. It is either in the form of penicillin or amoxicillin. And it is given for at least 2 to 3 years after splenectomy. But in the latest edition of Sebastian, it is written that one of the guidelines, the Australian guidelines, say that it is given till 10 years of age as well. So there are different guidelines, but you will use it for at least 2 to 3 years after splenectomy. So this was regarding OPSI. There's one more line in Bailey and Sebastian which you should know about. That if there is a dog bite or cat bite following splenectomy, they can also get infected because of Capnicytophaga carnimosus. This is an organism which can cause infections in patients following splenectomy. If there is a dog bite or a cat bite following splenectomy, this can be Capnicytophaga carnimosus, which can give rise to infection. So these were the complications following splenectomy, and majority of the questions regarding this module have been asked regarding the complications following splenectomy. And for short notes for the college exam, there's just one short note from this module, and that is OPSI, which is very, very important for your college exams. Before we end this module, let's just do some MCQs. You need to consider the following statements regarding OPSI. This was asked in the UPSC exam, but can also be asked in the INI CET exam. Haemophilus, Neisseria, and streptococcal are the most common causative agents. This is true. Risk is greatest in patients who've undergone splenectomy for trauma. This is false. I've told you it is greatest in those patients who've undergone splenectomy for hematological conditions. Risk is greatest within the first 2 to 3 years after splenectomy. This is true. Prophylactic vaccination should be done prior to elective splenectomy. This is also true. So the statements which are correct are 1, 3, and 4. This was asked in the exam. The downward displacement of the spleen is prevented by which of the following ligaments? I've told you it is phrenicocholic, which prevents the downward displacement of spleen. The most common site for accessory spleen or spleniculi is splenic hilum. You have a 45-year-old male who comes with complaints of abdominal pain, and there is a history of abdominal trauma 10 years back, following which splenectomy was done. CT shows multiple scattered nodules across the omentum and bowel lobes. Patient undergoes surgery and the biopsy reveals splenic tissue. I've told you this is the classical history of splenosis, where you will have a history of splenic trauma and you will have these nodular growths all across the abdomen, but they will just turn out to be normal splenic tissue. The most common complication following splenectomy, it is not OPSI, it is left lower lobe atelectasis or respiratory complications. Patient is undergoing splenectomy for ITP. What is the best time to transfuse platelets? It is after ligation of the splenic artery. So these were the questions regarding this module. Please focus on splenic trauma, which is given in the abdominal trauma module. and on the complications following splenectomy. A topic which has been asked frequently is splenic artery aneurysms.